I'm continue with the topic of new health technologies in achieving LDL target level in high-risk atherosclerotic cardiovascular disease patients. It's, you will agree, it's a very, very important topic. So, nothing to declare regarding this presentation. We know that nowadays in the world, the cardiovascular disease is the main killer. In fact, it's leading #1 cause of death, not only in Bulgaria, but in many, many other countries in Europe and both Americas. So this is a comparison between the regions, low-risk regions of Europe compared to, like ours, high-risk regions of Europe. You see how bigger is the proportion of very high risk for atherosclerotic vascular disease patients in our region. And the Da Vinci trial, that is a cross-sectional study of patients receiving lipid-lowering therapy between June, in fact, for 1 year. And it showed us what is happening with the utilization of the proper therapy and the goals achievement. Okay, let's see what happened. Despite these patients were very well monitored, it resulted that overall 54%, only 54% of the patients monitored attained the overall risk-based 2016 goal for lipid lowering. So, as one of the biggest risk factors, the lipid level, especially the LDL-C values, are very, very important. And not only in Europe, this was the European trial, but also in USA. These are the USA data showing that both in primary high-risk prevention and secondary prevention, you see that is a significant gap of patients not given or not taking statins, and there is quite a big proportion of patients not achieving the targets, not only because of that, but also because of physiological parameters. And one of the, let's say, model by clinician point of view, model of high risk are the patients with familial hypercholesterolemia. And this is the comparison between these extremely high-risk patients with FH compared to all the others. So it's very well seen that not only their LDL cholesterol is high, but also the risk, the clinical risk is higher, and the difference is extremely high. So these kind of patients are very important, and because of that we performed 5 hospitals multi-center trial showing that among the patients with acute cardiovascular event, around 6% of these patients, in fact, correspond to the FH criteria, the Dutch criteria for FH. And in this cohort of patients, observing between 11,000 patients, it resulted very important that the family history of hyperlipidemia, these patients have much higher level of LDL cholesterol, and unfortunately they have higher risk for clinical events. The problem is not only in Bulgaria. I'm not criticizing only our national system, but these are our data. It resulted that even this very high risk group, a very low proportion of these patients received statins before coming to the hospital, and it was increased to only 22%. So only half of the patients that are corresponding to Dutch criteria for FH are receiving statin therapy. And no, it was not surprised. We were not surprised to see that 12 months after the dehospitalization of these patients, only a very small proportion is achieving the target from the guideline. So extremely low proportion rate of achieving the target for the treatment in order to reduce the cardiovascular risk in this very high risk proportion group of patients. And also, like published by Reimer, very similar to our results, you see that because of the interruptions into the treatment, we know that the adherence to therapy is crucial in order to achieve the points. And I mean, many patients, independent on the risk profile, many of the patients allow themselves to interrupt the treatment, and because of that, in many cases, even in PCSK9 inhibitor, not only statins, even in PCSK9 inhibitor adherence, there are some interruptions into the therapy. From the daily practice, we know that many times, it's ridiculous, but it's true, many times when the patients are achieving the goal, they decide that they are already treated and healed, and they stop the therapy. That is absolutely stupid, but it's true. And this is showing also into the trial, not only in our daily practice, that both for high risk in yellow and low or moderate risk, not only the adherence, like shown in EuroAspire 5, not only the adherence, but also the achievement of the target rate is very low. And it's a pity because the higher is the LDL-C and longer is high, the earlier the accident, the cardiovascular accident are happening. And it was shown exactly again in our trial. Our trial showed that in general, the FH patients are 13 years younger than compared to the other, not FH positive patients, to receive a cardiovascular acute accident. And of course, they are not only younger, but they have more risk factors. So these are really a very high risk for complications group. And the good news is that the opposite is also true. The longer and the lower is the LDL-C concentration into the blood, there is a chance of a reduction of the cardiovascular events. So, and because of that, this is the reason, the trials and the evidence is the reason that in the last guideline, you know that for the patients with very high risk, the target for LDL-C went down to below 1.4 and even below 1.1 for the patients with extremely high risk. So you see, this is a very important target, and because of that, the algorithm into the guideline is stepwise. So we are starting with the baseline, of course, statins, but in case we don't achieve the goal, the patients don't achieve the goal, we add ezetimibe. And after that, in the patients that are very high risk, and even for primary prevention for heterozygote and homozygote familial hypercholesterolemia, we have to add the PCSK9 inhibitor. So we are opening now the door of the PCSK9 inhibition. There are another player. After the evolocumab and the antibodies, the monoclonal antibodies, a new player on the market with very good evidence into the trials. This is in fact inclisiran, that is completely new by mechanism of action. It's based, in fact, again on the reduction of PCSK9 protein expression. The PCSK9, you know, after reducing the PCSK9 concentration, the LDL surface receptors are more pronounced, more abundant, and the higher the LDL receptors on the surface of the hepatocyte, the lower the LDL cholesterol is. So we need, with our in fact, body needs the LDL receptors in order to reduce the LDL-C. And this PCSK9 protein, we have to reduce the concentration of the PCSK9 in order to in fact, to express more LDL-C, because it's some kind of inhibitor of the receptors. And in this situation with the inclisiran, in fact, the mechanism is a little different. The CUMAP, let's say, substances like evolocumab, in fact, it's not antibody, but it's a special, it's a new bio treatment that is based on RNA. And in fact, this RNA inhibition is extremely very important, because the PCSK9 protein needs the RNA, the informatic RNA, in order to be produced. These two gentlemen, in fact, they won the Nobel Prize because of discovering the RNA interference genes silencing. So it resulted that the RNA can be silenced, not killed, but reduce the RNA activity. So in this situation, we need such an agent that it's in fact impeding the RNA the possibility to stimulate the production of PCSK9. And in fact, this is the inclisiran. It's a double-strand silence inhibition RNA substance that is very interesting. It's really genius. It's the idea is really fantastic, because it's extremely efficient, and no doubt it's so specific that there is no source of complications, because it's absolutely specific for this specific RNA that has something to do only with the PCSK9. And the only place that we have PCSK9 protein is the in fact, into the hepatic tissue, hepatic cells. Okay, so this is the mechanism, and you see the steps of the mechanism. So after the inclisiran is released from the endosome into the cytoplasm, in fact, it's interfering with the RNA that is stimulating the PCSK9. And after several very important steps, in fact, he finally succeeded to cleave and to degrade the mRNA. And it's very important, and that for this hepatocyte, it's forever. For this particular hepatocyte that is, in fact, touched by the inclisiran, it's forever. And because of that, the effect of the inclisiran is so prolonged. You are going to see after that what is the treatment regimen. So there were many trials. I will show you several of them, very important. The Orion group of trials, in fact, these are the phase 3 already, Orion 9, 10, and 11. And because of the results, this was the reason they to enter into the consensus documents. So let's see, Orion 9 is including the heterozygote familial hypercholesterolemia patients. Orion 10, atherosclerotic cardiovascular disease proven positive patients, so patients with coronary, peripheral, and atherosclerotic brain disease. And also patients, the Orion 11, these are diabetic patients that you know it's in fact equipoise between the diabetes 2 and the cardiovascular risk. So these are three relatively different group of patients studied, but the common for them is that they are with a very high cardiovascular risk. And what are the common key inclusion criteria? Of course, above 18 years of age, with high levels of LDL, and it's, in fact, the design of all the three trials was absolutely one and the same. You see the day one, the medication is by subcutaneous injection. So inclisiran is applied subcutaneously, subcutaneous injection. And the primary endpoints are the LDL-C levels from baseline to day 510, so almost 2 years. And of course, the other one is time-adjusted percentage change in the LDL-C levels from baseline after 90 days, and again, almost 2 years after that. So, and there are several key secondary endpoints. I will tell you about also the secondary endpoints. These are, in fact, the patient characteristics. It's quite important to emphasize that unlike the registries that I have shown you, the statin use was very high, very, very good, around 90% for all the three trials, and even more. Almost more than 70% were on high-intensity statin use. So they had a very good adherence to statin use therapy, and they had ezetimibe in the Orion 9. There was a group of patients, more than half have used also ezetimibe. And on top of this good therapy, despite of, and this patient didn't achieve the targets. They stayed with very high LDL-C, so they completed the inclusion criteria. Despite the, I would say, perfect therapy, they didn't achieve the goals. And what happened after the inclisiran? Of course, the other group, 50% of the patients were on placebo instead of inclisiran. So it's a double-blind comparative trial. So what about the first key point, endpoint? This is the percentage, relative percentage reduction from the baseline, you see, compared to placebo. Like expected, into the placebo group, there was a slight increase into the LDL-C level during the investigation. And into the inclisiran group, there was 40% in the first trial, above 50% in the second, and almost 46% in the third trial, a reduction of the LDL-C from the baseline. And regarding the absolute reduction, this is the second endpoint, compared to the level, to the absolute, to the level of the LDL-C from the baseline. This is the reduction, the percentage reduction compared to the baseline LDL-C level. And this is very important because, you know, into the guideline, one of the component of the target when we are applying, especially in high-risk patients, when we apply lipid lowering therapy, one of the target is not only the absolute value, but the percentage reduction. So our requirement is to have at least 50% reduction compared to the initial level. And this was achieved with the inclisiran in all the three trials in this very high risk group of patients. And you see this is schematically shown what is the, it's enormous, it's a huge difference compared to placebo. compared to placebo, and this is the percentage, and it's up to 74% of the patients into the Orion 10 and 11 were able to achieve the guideline recommended LDL-C level below 1.8 millimeters with inclisiran, and this is really very, very important for our patients. But it was interesting to see that not only the LDL-C levels were changed, and we saw a reduction also into the total cholesterol. It's more than obvious because the LDL-C is one of the components. But also we had some reduction into the ApoB. It's modern, you know, nowadays ApoB and LPA new risk factors, let's say, and you see there is a decrease also in the level of these two components, and also a relatively moderate increase into the HDL-C level. Extrapolating data, we know how important are the LDL-C levels and to be maintained. And extrapolating this data and comparing 100 patients on statin treatment only compared to 100 patients on statin plus inclisiran treatment, you see that we can expect the following. So we can expect in a huge proportion of the patients to achieve the goal below 2.6. Significant, you see what is the difference, 14 compared to 76, to achieve the more strict goal of 1.8 for the patients with high risk. And you see this here, almost nobody is achieving the goal 1.3, below 1.3 into the only statin treatment. And quite a big proportion of more than 50% of the patients are receiving this goal that we have discussed in the beginning, that this is the new goal for extremely high risk. You see that more than 50% we can expect with extremely high risk of patients to achieve this goal. And this is an observation that is still it's not the target of our treatment, but who knows, one day we can have even more pronounced target. Even this very low level of LDL-C is achieved by 16% of the patients. And this is the pool analysis in the Orion phase 3. Of course, like in the medicine, in many cases, when we achieving some target, we are asking ourselves, okay, but what is the price? What are the complications and adverse event? It resulted that the adverse event is absolutely equal with the placebo. You see that nasopharyngitis, upper respiratory tract infections, hypertension, arthralgia. Arthralgia is important. You know that not 1 and 2 of the lipid-lowering agents cause arthralgia, myalgia, and so on. So, in fact, the complication, the adverse event rate is absolutely the same between placebo and inclisiran, and of course, this is more than important for us. Also show here regarding not only the adverse events, but also regarding the clinical adverse event, absolutely without any difference. And this is the administration. I mentioned already that in fact, the mechanism of action, and because it's permanent, so the inhibition of the PCSK9 and the inhibition of the mRNA that is responsible for the PCSK9 protein, in fact, synthesis, it's permanent, and because of that, the regimen is very interesting. So this is on the day 1, first application, after 3 months, second application, and after that, 2 times a year, so every 6 months. It's more than obvious that even a patient cannot remember that on 1st of August, let's say, has to make the injection. Even if the injection is applied 20 or even 30 days after this time, it doesn't matter because it's very, very prolonged action. So 2 times a year, extremely easy. And into the trials, it was definitely shown that, in fact, the adherence, it dependent on the number of applications of a medication. And unfortunately, the non-adherence is related to not achieving the laboratory and clinical goal. And you see that the higher the adherence, that is more than obvious, we can expect that can be higher in the situation of only 2 times application of per year of the medication. We can expect really the higher the result. And this is also coming back to the first slides, showing that the longer the time the LDL-C goal is achieved, the bigger the probability of reducing the cardiovascular events we have in the clinical practice. And this is in fact the summary. Briefly, so the atherosclerotic cardiovascular disease and events is one of the biggest killers nowadays. And the current evidence suggests, in fact, it's proven that there is a direct relationship to the LDL-C levels, these cardiovascular events. And the lowering of the LDL-C, we can expect a reducing of the clinical events. Many patients treated with statin-based lipid-lowering therapy are unable to consistently achieve not only not adhering, but also the patients with good compliance. And the inclisiran is the first and only therapy that utilizes the siRNA mechanism of action to lower LDL-C through inhibition of the PCSK9 protein production. And it's achieving, in fact, very long reduction of the LDL-C because of the unique mechanism of action. And it's very important that this goal is achieved without any signal regarding the adverse event, regarding the safety. And inclisiran is appropriate for people with elevated LDL-C levels who do not achieve guideline recommended with only 2 doses per year. And thank you very much for your attention.
Thank you, Professor Petrov. Colleagues, are there any comments or
new
questions?
Ideas for new medications?
Yes.
And Nobel Prize winners?
To share your experience.
Okay.
Okay.
Thank you so much.